I'm Sanjeev Bhalla, and I'm the Section Chief of Cardiothoracic Imaging here at WashU in St. Louis, Missouri. One of the kind of Achilles heels of many diagnostic radiologists and many people who will look at imaging as part of a practice not in diagnostic radiology is how do you evaluate lymphadenopathy? And lymphadenopathy is interesting because if you think of most lymph nodes, they are elliptical, they're kind of ovoid like an egg. And so early studies demonstrated that the most reliable, consistent finding was the short axis of the egg. You can always make the long axis of an egg shorter by parallax. So if the obliquity is different, an egg can appear shorter in the long axis, but it'll never change the short axis. So the short axis will always stay consistent regardless of the obliquity or the parallax. So for that reason, the short axis measurement of a lymph node is the most important. I think we often will give bidirectional measurements or we focus on the bidirectional measurements, but it's the short axis that is the most important when anatomic imaging is taken into consideration. The second big thing is to try to get a sense of the morphology. If the lymph node, which takes a shape very similar to a kidney, has a fatty hilum, it's much more likely to be reactive. But if it takes on a round shape or there's obliteration of that hilum, then it suggests that the lymph node is diseased. So we try to look at both of those if possible. Now, in the mediastinum, for anatomic imaging, the key is to look for a short axis of about 1 centimeter. So if you're dealing with lymph nodes that are in the right paratracheal, the left paraortic, the AP window, that's where 1 centimeter is really key. But it's useful to keep in mind that there are some lymph nodes that violate that rule. So the first one is the subcarinal. Subcarinal lymph nodes are notoriously bigger, and so we use a short axis measurement of 1.3 centimeters for subcarinal lymph nodes. So if you see a subcarinal lymph node, then you'd be willing to accept up to 1.3 centimeters. And the same token, supraclavicular lymph nodes are unusual to see on CT. And so the threshold drops to 8 millimeters, 6 to 8 millimeters. So if you see a supraclavicular lymph node that is greater than 6 millimeters, then we start to kind of hone in on it and focus. Now, there are certain lymph nodes that you almost never see. And if you see those, it's worthwhile being concerned that they could be pathologic. The classic example of that is the internal mammary lymph node, that if we have a patient with breast cancer and we do a chest CT and we see an internal mammary lymph node, we have to be really worried that it is diseased because it's very unusual to see a lymph node in that chain. Now, not everything is going to be lymphadenopathy from metastatic disease, but certainly if you have a lymph node that's greater than 2 to 3 millimeters. Now, other lymph nodes that are a little bit unusual are the anterior pericardial lymph nodes that sit right at the cardiophrenic angle, or the middle diaphragmatic nodes, which sit near the inferior vena cava. Those can be enlarged if there's cirrhosis or hepatic disease. But if you see those in the absence of those conditions, you have to be a little bit concerned too that something is going on. So we try to look at the shape and the size to help us. And with all of that, CT still is somewhat questionable in its value. So we find that the accuracy of CT for lymphadenopathy when contrasted to a mediastinoscopy, for example, is still in the upper 70 percentile. So it's not that great. When you add a metabolic imaging like PET CT with FDG, then it increases the sensitivity, but there is a drop in specificity because you'll see that granulomatous conditions can have uptake. But we try to weigh both of those together, and in the right patient population, they can avoid some invasive procedures, but almost all of the patients that are going to get some sort of extensive resection will have some tissue sampling be performed prior to undergoing a lobectomy, either an EBIS or they'll get some sort of a mediastinoscopy. But right now, it's pretty much the size of the short axis that's the most important, with a secondary feature of looking for that fatty hilum and looking for that shape of the lymph node.